There's new guidance for when and when not cardiac catheterization may be appropriate. I'm with Dr. Manesh Patel, who is from Duke University. This is the first time these documents have been updated for, I think, 2001. You've gone through 166 clinical procedures. How much fun was this over the last period of time?
It's quite a bit of work, and I want to, acknowledge that I'm one of many in the writing group that had the opportunity to develop the criteria. Roughly a year's time with once a week to twice a week phone calls for everybody. So a lot of commitment. And to be clear, these are appropriate use criteria for diagnostic cardiac catheterization, which have never been done before. And our hope is to continue to provide some guidance to clinicians, to patients, and to payers on when and when not to do some of these tests.
I don't want to go through all 166.
Sure, yeah.
What percentage ended up being appropriate criteria?
Yeah, so inappropriate was about 16%, and the rest are appropriate or uncertain, which we say is generally things that we think is reasonable or may be reasonable to perform. And you can envision that the inappropriate reasons are fairly unusual or hopefully unusual. Not to say they can't be done sometimes because of clinical judgment or unusual circumstances, but we have things like asymptomatic patients with low-risk features. Generally, you wouldn't go to cardiac catheterization as the first test, or preoperative testing often is non-invasive before you go to cardiac catheterization. Yeah, so we should be clear about the terms because it does cause people a lot of angst when you say the words appropriate or inappropriate or uncertain. These terms were taken from the RAND method, and we hope to continue to have a dialogue with the community because many have said, well, shouldn't we have something different, maybe possibly appropriate or things like that. One of the things we've done is start to talk to the stakeholders. We put this for patients, clinicians, and payers, and so uncertain currently is defined as something that may or may not be appropriate, and so it's maybe reasonable to do.
And
you can recognize this, not even extenuating. We recognize that a lot of medical practice right now is uncertain. If you had to have a randomized clinical trial to say this is reasonable all the time, the vast majority of our practice, the guidelines as they exist, don't have that data. So it's okay to have uncertainty. It's just the word uncertain makes people feel uncomfortable, especially when you have to convey it to patients or to payers. But we're hopefully doing more education to say this is an area where more research is done, but it's clearly very reasonable care.
And for inappropriate, for the vast majority of cases, it's probably not appropriate, but there may be...
So you can envision that a lot of people are evaluating our practice, and we say population-based practice patterns. There's no one clinical situation any writing group could understand with a patient-physician interaction. There are always extenuating circumstances. I can't write a 4-bullet case scenario that captures all the patients going through cardiac catheterization. But in general, if you were to evaluate your practice pattern over a year, would there be a lot of asymptomatic low-risk patients that went directly to the cardiac cath lab or patients without symptoms getting procedures? So what we ask for inappropriate often is that we evaluate patterns of care, and sometimes when the extenuating circumstances exist, you have to document that. Now, unfortunately, a lot of our members and clinicians are saying, I'm getting the insurance company saying, that's inappropriate, I can't do that procedure. You guys are leading to this problem. And our hope is that they recognize that this was happening before the appropriate use criteria came out, and this is going to happen whether they're here or not. And part of this is the society and the physicians to lead as a profession to say, when is it reasonable to do a test?
Any bullet points or headlines from within this document that you think?
Well, it's always interesting when you do these and you think you've evaluated the evidence and it gets out into practice, you find out things. And so my hope here is that most of the people will say, yeah, this makes sense. This isn't anything new to us. This is how we've been practicing. But, there are always unintended consequences with how things are written. So we'll try to find out if there are areas where we can increase the clarification. One important point we're doing is, unlike the appropriate use criteria for coronary revascularization, which we're updated and we've worked a lot on with a lot of people, here we're working with SCAI and ACCF and other groups to develop a referral form, hopefully a 60 to 90 second tool that'll be published with the paper that allows primary physicians to check the reasons they want a left heart cath or a right heart cath. So the onus isn't directly on the interventionalist or the cardiologist, it's on some of the other physicians that are often at the point of order asking for a procedure.
And we should probably say, too, that this document was done in consensus with SCAI.
Absolutely,
and,
yes.
the ACC acting not alone, but with SCAI and with STS and other organizations.
Yeah, so I'm here with you at the SCAI meeting, and it's being released today, as you know, and so it is in conjunction with the societies that involved in doing invasive procedures.
Terrific. Thank you very much. For CardioSource Interventional News and CardioSource World News, I'm Rick McGuire.